Hi, everyone. We are just waiting till the 12 o'clock hour. Um, so we'll just wait here for a few minutes until we can get everyone in. Okay, it is 12 o'clock and I'd like to respect everyone's time. So we are going to get started. Welcome to the Health Professional Webinar, Urea Cycle Disorders, Recognition, Diagnosis, and Management. If you are looking at the screen, you'll see the slide from our nursing practitioner over at Texas Children's Hospital that gives information about the CEUs on nursing. We will email more information as we continue, but just so you have this disclaimer in front of you. Before we start, I just want to make sure that everyone knows that you must attend the entirety of the webinar to receive credit. And within 24 hours of the ending of this webinar, you will receive an email with information on how to attain those CEUs. So we'll have direct links for surveys for you to complete in order for you to get the CEUs. Certificates may take up to 10 business days after you submit your survey. So it's not after the seminar, it is after you submit your survey. And of course, it depends on the volume of attendees, but hopefully we can get those sent out to you as soon as possible. For the social work CEUs, if you are a social worker and would like a free 1-hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin Office of Professional Development, School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those of the School of Social Work or the University of Texas, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the school or university. So today we have two presenters, Dr. Lindsay Burrage and Laura Buckner. So I'm going to just read a short introduction for Lindsay, and Laura Buckner, of course, likes to introduce herself. So for Lindsay, we have that she is a pediatrician and clinical geneticist. Her primary clinical interest is in the diagnosis and management of a wide range of genetic disorders. She has a particular interest in diagnosing and management of inborn errors of metabolism and skeletal dysplasias. She strives to provide evidence-based care to all of her patients. In addition, she enjoys partnering with each of the families in her clinic in order to personalize the care that she provides to each patient and family. So thank you so much, Lindsay, for joining us. And I am going to let you take over. Let me stop sharing and you can share your slides.
Can you see the slides okay?
Yes, we can.
Okay, and is the closed captions working?
I don't see them.
Okay. Let me share it a different way. Okay, is that working now?
That's working. Thank you.
Perfect. Okay. So I'd like to begin by thanking Gladys for that introduction and to thank the organizers for giving me an opportunity today to talk to you about urea cycle disorders, the recognition, diagnosis, and testing. I'll begin with a disclosure slide. I have no financial conflicts of interest for this talk. I do serve, though, in a voluntary capacity on the medical advisory board of the National Urea Cycle Disorders Foundation, and I'm also a member of the Urea Cycle Disorders Consortium. I receive funds from the NIH and philanthropy to support my work in urea cycle disorders. The objectives of my talk today are to help folks recognize symptoms of high ammonia levels in infants and children, review the standard collection and processing of blood ammonia levels, and to discuss basic principles of the management of urea cycle disorders. But before we jump in and talk about the urea cycle disorders, we need to first step back and talk about inborn errors of metabolism. Inborn errors of metabolism, or IEM for short, are genetic disorders that result from a block in a metabolic or biochemical pathway. These disorders typically involve enzymes that are important in metabolic pathways or transporters of metabolites for these metabolic pathways. The inborn errors of metabolism are a large group of disorders that can present in a wide variety of ways and at varied ages, ranging from neonates all the way to adults. So why is it important to learn about inborn errors of metabolism? Well, perhaps you work in a PCP office, or perhaps you work for the state newborn screening lab. It's important to understand inborn errors of metabolism in those cases so that you can appropriately manage newborn screens. So the state newborn screening program is a program that screens newborns for treatable disorders prior to the onset of symptoms so that early therapy can be initiated. For this newborn screen, blood spots are collected, usually with a heel prick, at 24 to 48 hours of life, and in Texas, again, at 7 to 14 days of life, to screen for a subset of inborn errors of metabolism and other disorders. But there are other reasons why it's important to learn about inborn errors of metabolism as well. Perhaps you work in a PCP office or in urgent care or an emergency center, and it would be important in that case to recognize the acute emergency presentation of inborn errors of metabolism so that appropriate management can be initiated right away. It's important to understand inborn errors of metabolism so that appropriate primary care can be given to individuals with these diagnoses. And also, an understanding of these disorders is important to facilitate appropriate perioperative care, as our patients may need special and unique provisions for their care in and around surgeries. And lastly, perhaps you're a social worker or a home provider for speech therapy or other therapies. It's important to reinforce the dietary and medical management for patients in your care. Many of our patients are on special diets. So for instance, if you're a feeding therapist, it's important to understand what are the appropriate foods that a patient with an inborn error of metabolism can eat. So now we can jump in and focus on one particular group of inborn errors of metabolism, the urea cycle disorders. And these are a group of inborn errors of liver metabolism. The urea cycle disorders, or UCD for short, impact approximately 1 in 10,000 people. We're not really sure of the prevalence because we think there are individuals who have these diagnoses, but it's unrecognized. And like the other inborn errors of metabolism, UCDs can present in newborns, infants, children, but also in adults. So to understand the UCDs, we have to first step back to biochemistry and revisit the urea cycle. The urea cycle is a series of enzymes, which I'm showing here in blue boxes. And the main goal of these enzymes is to process nitrogen into a safe waste product called urea that the body can excrete in the urine. This waste nitrogen comes from our diet. It comes from the protein components in our diet because the proteins are made of amino acids, and those amino acids contain nitrogen, and this nitrogen needs to be converted to urea to safely excrete it from the body. Now, the entire urea cycle shown here, all 6 of these enzymes, it only works together in the liver to make urea. However, some of the individual enzymes are present elsewhere in the body. So to reiterate, the functions of the urea cycle are to generate urea, a safe waste product from waste nitrogen. It allows for the elimination of about 40 to 50% of dietary protein that's not needed for growth and maintenance. And it's also important because some of the biochemicals in the pathway serve as intermediates to produce other biochemicals that are needed for other functions. So what happens when one of these enzymes is not working right? If one of these enzymes is deficient, that means the body can't make urea as efficiently. So the waste nitrogen from the protein that we eat builds up in the form of a neurotoxin called ammonia. So ammonia is a neurotoxin that interferes with brain metabolism and neurotransmission, and elevated ammonia can cause astrocyte swelling, brain edema, and herniation. So elevated ammonia levels are an emergency. So how do we know if one of our patients might have a high ammonia level? Well, there are a number of different symptoms of high ammonia levels, and those symptoms can depend on age. So first, we'll talk about the symptoms of high ammonia levels in infants. And these include poor feeding, lethargy, not acting like self, super sleepy, difficulty waking. The infant may have respiratory distress. They may have vomiting, and it may progress to seizures and coma if not recognized and treated. Now, for those of you who many of you may recognize that these symptoms look like sepsis or a neonatal infection. And it's true that the symptoms of hyperammonemia or high ammonia levels may mimic neonatal sepsis. So it's important to recognize this overlap and consider measuring blood ammonia levels in infants where there's a suspicion of possible sepsis. Now, toddlers and older children, as well as adults, can have some different symptoms. They might have chronic intermittent vomiting. They may complain of headaches. They may also have lethargy or altered mental status. In some cases, a parent may report that a toddler refuses to eat high-protein foods like meat, and even an adult may tell you that they feel funny when they eat high-protein foods like meat. They may have behavior changes. They may complain of nausea. Folks may note confusion or disorientation, anxiety, and like the infants, this can progress to seizures, coma, and death if untreated. In adults in particular, it's important to recognize that the symptoms of high ammonia may mimic psychiatric illness or drug or alcohol intoxication. And so when folks are evaluating adults for these issues, it's important to consider whether a high ammonia level should be checked because high ammonia levels can present similarly. So once you're evaluating a patient and you decide it's important to consider a blood ammonia measurement, it's important to understand some factors about how best to draw and process the blood sample in order to get accurate ammonia levels. First, the preference is for a free-flowing sample, preferably not with a tourniquet if possible. But certainly, if it's a really tough draw, it's important to note that in the medical record because that could impact the interpretation of the level. The sample should be placed immediately on ice, and it should be run on site with results available in about 30 minutes. Sending an ammonia level off to a reference laboratory in another state can be problematic because it can lead to false elevations in ammonia levels, and it's best to have a laboratory on site that can provide results within about 30 minutes. And of course, when we're interpreting blood ammonia levels, we have to check the collection time and result time to verify timing because, as I already alluded to, prolonged processing time can lead to a false elevation. These are all important factors to consider because, as I mentioned, ammonia is neurotoxic and high ammonia levels require emergent treatment, and so time is of the essence. But it's also important to collect samples so that we can get the most accurate results possible. So what are some risk factors for elevated ammonia levels? So when you're collecting the history of a patient who presents with some of these findings, you may be able to identify some risk factors for the elevated ammonia levels. This could include fasting. So if a patient goes too long between meals, the body can start to turn to its own protein and break its own protein down. This protein also contains amino acids and nitrogen that then leads to the urea cycle, goes into the urea cycle to make urea. So if it's not functioning, ammonia will build up. Patients may report a high dietary protein load, an intercurrent illness or rapid weight loss, which are also catabolic stressors that could cause protein breakdown in the body. Poor food intake. In women, menses can be a trigger, as can vomiting illnesses, surgeries or surgery preparation, the postpartum period. There are certain medications like steroids and valproic acid that can increase risk for elevated ammonia, as can infections and other external stressors. It's important to recognize these risk factors because it could be one of these risk factors that triggers the initial presentation of an elevated ammonia in a patient, or one of these could trigger a metabolic crisis in a patient who has a known diagnosis. However, in some patients with a UCD, we may not identify an obvious trigger to their elevated ammonia level, and we may never know what actually triggered the event. Additional history that could be supportive of a possible urea cycle disorder diagnosis. We've already hinted at unexplained or intermittent vomiting, protein avoidance, but other things like intermittent unexplained elevation of the hepatic transaminases can sometimes be explained by an undiagnosed UCD. Intermittent altered behavior, unexplained psychiatric symptoms, and family history may be informative in some cases, but not all, and a negative family history certainly doesn't rule out a urea cycle disorder diagnosis. So once you've confirmed an elevated ammonia level in the blood of your patient, what's the next step? Well, reaching out to your local metabolic genetics specialist for advice on management and diagnosis is important. And it's important to do that immediately. This is not something that can wait till the next day or that can wait over the weekend because, as I mentioned, elevated ammonia is a life-threatening emergency, and it's important to get the appropriate management as soon as possible. Now, as we're treating the elevated ammonia level in an emergency center and often in an intensive care setting, we're also trying to figure out which of the urea cycle disorders a patient may have. So here I'm showing the 6 enzymes of the urea cycle, all shown in blue, and any of these enzymes could be deficient, causing the urea cycle disorder in any given patient. However, Today, I'm going to only focus on one of these, OTC deficiency. And that's because OTC deficiency is the most common of the urea cycle disorders. The estimated prevalence of OTC deficiency is approximately 1 in 15,000. But as I alluded to before, we suspect that there are patients with OTC deficiency who are unrecognized and who may not realize they have this diagnosis. OTC deficiency is also unique amongst the urea cycle disorders because of its X-linked inheritance. And because of the X-linked inheritance and because of the fact that males have one X chromosome, males typically have a severe early onset presentation, although that's not always the case. Females, on the other hand, have two X chromosomes, and because of X inactivation patterns, can have a wider range of presentation, ranging from early onset to apparently asymptomatic, but still at risk for high ammonia levels in the right setting or with the right stressors. Both females and males can present with acute liver failure as their very first sign or symptom. And mothers of affected males may not realize that they're affected until their son is diagnosed. And it's common for us to diagnose moms with OTC deficiency at the same time that we're diagnosing their children, males or females. Now, the other reason it's important to know about OTC deficiency is because OTC deficiency is one of the urea cycle disorders that happens to not be covered by the newborn screening. So I showed you 6 enzymes in blue boxes on the previous slide, and 3 of those are included on newborn screening and 3 of them are not. And so for some of the UCDs, newborn screening is one of the ways we make the diagnosis, but that's not true for all of them. And so for some of the disorders, the patients may present asymptomatically, and our first way we diagnose them is with the abnormal newborn screen. And in these cases, it's important to follow your Texas Act sheets on the DSHS website to follow instructions as how to get them care as soon as possible and keep them safe. And of course, always contact your local metabolic genetic specialist who can provide guidance and assist with management. But as I mentioned, not all UCDs are covered by the state newborn screening. And in fact, OTC, the most common UCD, is one of those examples. And so it highlights why it's important not to rely on newborn screening, because if you do, you won't diagnose one of the first 3 enzymes of the cycle, at least in the state of Texas. And these patients, their first presentation may be high ammonia levels. And so that's what recognizing the symptoms and then collecting a blood ammonia level and checking it will often be the first way you have a clue that a patient has one of these first 3 enzyme deficiencies. And this is in contrast to the final 3 enzymes of the cycle, ASS1, ASL, and ARG1, which are typically included in state newborn screening programs. So how else can we diagnose the UCD? Well, that would be through biochemical testing. Your ammonia level is one example of that, but by checking plasma amino acids, you can see the different biochemicals in the cycle and see which ones are elevated and which ones are low, and that will give you a clue to a UCD diagnosis, as can measurement of urine orotic acid, another biochemical that can be produced in certain urea cycle disorders. And then, of course, genetic testing can help us get a molecular confirmation and is important because getting a molecular diagnosis can help facilitate genetic counseling and testing of at-risk family members. Once we have a diagnosis, how do we manage our patients? Well, one of the mainstays of UCD therapy is restriction of dietary protein with special metabolic formula. And why is this? Well, if we go back to one of the earlier slides to remind you that this nitrogen comes from the dietary protein that we eat. And so by restricting protein in the diet, we can restrict the accumulation of waste nitrogen and the production of ammonia. Now, we can't take protein away entirely because we need those amino acids for growth and development. So we have to walk a tightrope to make sure we give just enough for growth and development and to keep a patient healthy, but not too much that they get hyperammonemic or have high ammonia levels. In addition to dietary protein restriction and special metabolic formula, depending on the enzyme deficiency, we may supplement with citrulline if citrulline is low, or arginine if arginine is low. Again, it depends on the disorder. And then we also use special medications called nitrogen scavenging agents, which bind waste nitrogen and divert it away from the urea cycle. All of this is important together with emergency preparedness and anticipatory guidance so that we can provide families with all of the important emergency numbers and all the emergency planning so that they can be prepared in the case of an event that triggers high ammonia levels. So what type of anticipatory guidance do we give? Well, all of our patients will have emergency letters. These are letters that provide the contact information for the metabolic clinic, but also the initial work, important clues and tips for the initial evaluation of our patients so that they can be safely cared for while the team is getting in touch with the metabolic specialist. In our older patients, we also recommend emergency bracelets, and in families, we'll recommend that emergency numbers are programmed into the telephone or into the cell phone so that patients can get to call us in any setting, in any emergency. We recommend that patients don't skip any meals because fasting is a trigger of high ammonia levels. We warn families of which medications should be avoided, and when they can't be avoided, we encourage families to reach out to us using our emergency numbers so that we can provide appropriate management. We encourage folks to avoid large protein loads. When we provide protein prescriptions, we want to make sure that protein is spread throughout the day because large protein loads at one time can lead to high ammonia levels. And then we also encourage avoidance of a seizure medication called valproic acid, which can increase risk for high ammonia levels. We encourage our patients to contact our metabolic team if they're having an intercurrent illness or if they have a need for surgery so that we can provide appropriate guidance for the NPO period prior to a procedure. So if you're in a general pediatric setting and you encounter a patient with a UCD who is vomiting, not tolerating feeds, or otherwise ill, it's important to reach out to us, encourage the family to reach out to us so that we can manage them appropriately to prevent a life-threatening hyperammonemic event. And then, of course, there's age-appropriate guidance. As our patients grow older, we have various appropriate guidance that we give for things like choosing a diet appropriately, teaching the younger children which foods are safe and which are not, so that when they get older and are making their own choices, they can choose appropriately. For our young women, discussions of menses and how this can trigger high ammonia levels, etc. And then lastly, it's important to provide genetic counseling for the patient, for the family, and offer testing for at-risk relatives so that we can identify other individuals in the family who may have the diagnosis or are at risk for having the diagnosis and provide appropriate management. This is particularly true for OTC deficiency, given the X-linked inheritance pattern, but it can also be true for testing for carrier status for the other autosomal recessive UCDs. With that, here are my references, and I'll hand over the slide to Laura.
Hi there, can y'all see me? Hear me?
We can hear you.
I don't see myself, so I don't know what that's about. Oh, there I am.
There you go. Yeah.
Took my computer a minute. Well, hi y'all, and let me see if I can share my PowerPoint. Oh, now it's asking to record the screen. Good Lord, here we go again. Give me a minute. I'm sorry I was late to the call. Share my screen. How do I find the PowerPoint? I'm sorry, I should have been on earlier to figure out how to do this, and that didn't happen. I apologize. Well, Gladys, do you have my PowerPoint that you could share it so that we don't waste time?
I do. I have it up.
Sorry. I'm sorry. Thank you very much. All right. So, hi, y'all. My name is Laura Buckner, and I am at the University of Texas at Austin, the Texas Center for Disability Studies. We have a collaborative effort with the Baylor geneticists. And I am not an expert on urea disorders, but I am a parent of a 36-year-old son who has a rare genetic disease. So I certainly know about scary diagnoses and trying to live a life in spite of those. I'm a licensed professional counselor, but I always like to say my most important degree is my M.O.M. degree, which I'm still earning because he's 36, diagnosed at 3 months of age with this rare disease. Go ahead, Gladys.
I've given you control, so you should be able to.
Oh, well, how about that? Let me see if I can do it. It's not moving. I don't know how to make it move, Gladys. It's not moving.
There it goes.
Just hit the space bar.
Oh, okay. I was hitting the arrow bar. Thank you. So, I certainly appreciated what your previous presenter spoke about, because this can be a scary thing, and can be a scary thing kind of fast from what I understand about it. So we certainly want to educate caregivers as well as school educators or other professionals who might be working with a patient or a child in school. And so we want to talk about how to recognize those warning signs. She talked about not skipping meals, where to call for help. But I think it's also important to note that there could be behavioral challenges associated with those concerns. And I know that a lot of times in the disability world, that when kids with a disability have, or some kind of medical issue, have some unique or what we like to call challenging behaviors, too often we resort to trying to eliminate the behavior, change the behavior, or even punish the behavior, instead of paying attention to maybe what the behavior might be trying to tell us. And I think in this case, that's going to be really, really important. Go ahead, Gladys. Oh, let me see if I can do it. I hit the space bar, but it's still not moving. So I'll let you do it, Gladys. Thanks. So I would suggest that you know, as a former educator, at the beginning of the school year, a lot of parents come in with all of their concerns for every one of their kids. You know, my child doesn't like this. My child isn't good at that. My child needs this. It's a lot for a teacher to keep in her or his head. And so we strongly recommend that you send a letter to the school that includes really critical information about this particular disorder and what the teacher or others in the school building would need to be aware of. And I'm going to show you in a minute how to do what we call a one-page description, which I think could be a really valuable addition to a letter to the school. But just a letter to the school that explains what the disorder is and what kind of things to watch out for and what kind of accommodations might be needed. Next slide, Gladys. These are some behaviors that, as I was educating myself about this disorder, and I think it was spoken to earlier, that might indicate an emergency with this disorder. And so, you know, if a child's in school and acting kind of sleepy or really lethargic, instead of thinking that child's just being lazy and not wanting to do the work, Maybe we need to check some other things out. Even irritability or unusual mood swings, personality changes, just not being themselves. Again, in the disability world, too often, professionals, even families, I've been there, we are too quick to see a behavior as something to change or eliminate or even punish. And in this case, that would be a really critical mistake. So we want to pay attention to these kind of behaviors. And these are things that you could include in your letter to the school or to whatever professional you're working with. Next slide. So I want to talk to you about creating what we call a one-page description. We used to call them one-page profiles, but the word profile has a negative connotation, so we changed it to description. And I think this could be a really valuable way of helping educate, for example, a school teacher or a physical therapist or whoever else you're working with, whatever kind of professional you're working with, in a way that's easy to read and keep right at your fingertips and even remember easier than a long letter. So we start with asking these three questions. Before we begin a one-page description, ask yourself these three questions. Where are we going to use this? To really be effective, a one-page description has to be very narrow in its focus. It has to be focused on a specific environment or setting or situation. For example, if you're talking to a school teacher, maybe it's a third grade classroom teacher, the context would be the third grade classroom. If it was people in the cafeteria at the school, the context would be the school cafeteria or the school bus driver. So you narrow your focus to a specific environment or setting or situation because it then narrows the information that is pertinent to that specific situation or environment. Where's it going to be used? What do you want people in that environment to know about this person? And lastly, how do we best support this person in this situation or setting, especially if there's an emergency or a crisis? Next slide. So I use school as the context because I think a lot of people on the call might be working with families who have kids in school who have this disorder. So you start with the very first box on the left. What do people like or admire about this child or this person? And many people think, well, what does that matter? Why do we need to have that? The truth is that when you're talking about somebody with a chronic illness or a disability, the focus goes laser focused on the disability, the disorder, the medical issue, what's wrong with the person. And I've known too many children and adults who have spent years hearing people only talk about what's wrong, what their illness is, what their disorder is, what the disability is. And it's not the sum total of who this person is. So we always start with what do we like or admire about this person or this child. We don't talk about functioning levels here, and we don't talk about the medical issues associated with this disorder. We focus on who the person is as a person. Just like how you would describe your best friend or your own child or somebody you love, that's what goes in that first box. You focus on that person's or that child's personality, their gifts, their abilities. And then you ask yourself, what's important to this child or this person in this context, and for this example, at school? What's important to this child in a third grade classroom? Or what's important to this child in a school cafeteria or on a school bus? What's important to them? And it might have something to do with this disorder. It might not, because in the third column of the one-page description, next slide, is how this person is best supported. We can go to the next slide. How is this person best supported in this context? And that's where you really can get down into the nitty-gritty information that somebody would need to know in order to support a child or a patient with this specific disorder. And how are they best supported? You know, too often we'll say, well, she has this disorder and you need to know this, but we don't give a whole lot of detail about what they need to know about that. So ask yourself, well, what causes this child anxiety or discomfort or fear? What makes this person feel safe? How does this person communicate? Are they capable of letting you know when they're having some symptoms of ammonia buildup? Is there some way that we can identify with their behavior or something they say or do? How do they express fear or discomfort? Because sometimes emergencies can be very scary, right? How would we know that that's experiencing, and what would we do to support them to feel better, to feel more comfortable? Let's say we had to call an ambulance or call mom because there's an emergency. While you're waiting for that emergency care, what helps? What would help this child at school? By then they're probably in the school nurse's office. What would help that child feel safe and comfortable? And what should we avoid? What would make it worse? Are there any other accommodations that we could make, or any other tips that would help the staff person help this person or this child at school? Next slide. You want to think about any kind of past traumas or trauma triggers that this child might have experienced. And, kids with, and even adults with medical issues often have experienced a considerable amount of trauma because of the medical concerns, perhaps other emergency situations or crises that they've encountered. Even going to medical appointments where there's a lot of examination can be a little bit traumatic for some. So you want to think about what kind of traumas this child might have encountered and what might trigger a trauma response for that particular child, because we want to try to avoid those. And you could build that information into that third category on the one-page description. How is this person best supported? Next slide. This is a template for a one-page description. It's very boring, but it's just a blank template to start with. I'm going to show you where you can find much more interesting and more fun templates in a minute. But this is a starting place where you could start taking some notes to yourself about what do we like or admire about this child, my student. What's important to this child or this person in this setting or environment? How is this person best supported in this setting or this environment? I know you notice up at the top I put for school because that's the context I chose for this particular webinar. The middle box says insert photo here, and I really encourage people to do to put a photo in there that's a flattering photo. A lot of people's medical files and school files have photos that are almost like a mugshot, and we don't want those. You can put a photo in there that not only is a flattering photo, but might even communicate a whole lot of information about this child with no words. For example, in my son's medical one-page description, the photo I have is a picture of him at the driver's seat of his Ford F-150 truck, of which he's immensely proud. But think about what that communicates to a new medical professional, for example, or some other professional working with him about who he is with no words. He drives a truck, and he obviously loves it because he's grinning from ear to ear. So think about what photos you could put in there, or a photo in there that would be not only flattering, but could communicate something about this person that's not a mugshot. Go ahead to the next slide. These are some examples of the more fun, more interesting templates I was talking about. There's a group in the UK, and they call themselves Chef Kids. I don't know why, but that's what they call themselves. If you Google Chef Kids, and you see it spelled at the bottom of that slide, just Google Chef Kids one-page profile, and they have two different pages, actually, two different websites, one for templates for adults and one with templates for children. And they're available for free download. They have every template known to man. You're into chocolate, they've got one. You're into pink, they've got one. You're into dinosaurs, they've got one. So you can choose a template, download it, and feed the same kinds of information we just talked about into that template. And there again, communicate a lot about this person, this child or this person you're talking about, without any words. You know, if you have a template that's full of pictures of dinosaurs, it tells who's ever reading the one-page description, okay, this kid loves dinosaurs. And it gives them a starting place to have a conversation, especially if you're in a crisis and waiting on an ambulance or for mom to get there. You know, wouldn't it be great to be able to talk to that person and tell me about these dinosaurs? So Chef Kids, just Google Chef Kids one-page profiles, and you'll come up with both the adult template page and the children's template page. Next slide. This is a link to a website that we, pardon me, not a website, a Powtoons little video clip that we did several years ago. It's available on YouTube, and the link is in this slide. It's just a reminder. It's me talking. Actually, it's not me talking. It's one of the gals I worked with, but I wrote the script. It's us talking about exactly what I've just gone through. A good reminder for how do you do a one-page description? What goes in each of those blanks, and what are we talking about? So it's a good way to kind of remind yourself what we're talking about if you decide this is something you'd like to try. Next slide. The last thing that I want to encourage every family member on the call, as well as professionals working with families on the call, is to help those families get connected to other people who are on similar paths. You know, as a parent of somebody with a rare disease, we don't know anybody in our rural East Texas community that has my son's disease. We don't know anybody. We never have. He's 36 years old. It's hard to talk to people about your specific issues related to this disorder because there's nobody that knows it. And so I really encourage people to get connected with others who are dealing with similar situations. And it might be at a state level or even a national level. I was in Washington, D.C. 2 weeks ago with my son's National Alliance. We were talking to legislators about funds for medical research into that disease. But it gives me a great opportunity to meet people from all over the country who have children and adults with my son's disease. So I always tell families, you know, there's great experts in our world, in the disability world. You know, there's great experts who know all about Medicaid, great experts who know all about Medicare, Social Security, genetics, medical research. There's all kinds of experts in our world. But most of those experts aren't walking the path that we're walking. And so they don't know some of the ins and outs of that path that people who are on the path have figured out. You know, I have some very good friends who work for Social Security, and I love them dearly, but they'll show up at a workshop with their Social Security brochures about how to apply for SSI or SSDI, and they're great brochures, but if you're not familiar with the system, you don't really understand all of it at first. And as I've told families, those experts don't stay up until 3 a.m. trying to figure out how to fill out an application, but I have. And other families on your journey have done the same. They're the experts you want to connect with. And this is one example of a website that you can connect people with. It's with the, I don't remember the name of it, but it's the next slide. And they actually have one on connecting families, but the next slide shows you the name of the organization. Thank you. It's the National Urea Cycle Disorders Foundation. And they have a specific link, which is the slide I had just before this, that specific to connecting families. And, you know, if you're a professional on the call, help families get connected to other people who are on that same path, and encourage them to get connected with those families. Sometimes it's hard to reach out to other people because you don't know, you know, is their child's situation just like yours? Is theirs worse than yours? You know, it's uncomfortable when, and I've had this experience, it's uncomfortable when your child is doing a little better with the rare disease than perhaps somebody else's child. And it makes the discussion kind of uncomfortable, but it's not a reason to not reach out, because you will find people who are on that same similar path as you and who know stuff that those experts won't always know. The next slide. This is another link to their page. And what they do, they say, we live to conquer them. It's the only nonprofit organization in the world solely dedicated to saving and improving the lives of children and adults from the catastrophic effects of urea cycle disorders. So it's a great place to connect people and encourage them to look into. Next slide. The last thing I'll say is a little bit about Medicaid waivers. Maybe you know what a Medicaid waiver is, maybe you don't. Every state in the country has a set of different Medicaid waivers. Every state is different. And Texas has a number of Medicaid waivers, but to get on a Medicaid waiver, and a Medicaid waiver might provide, it might put the child on Medicaid, but it also might provide attendant care or nursing care or respite care, even home modifications if they're necessary. But to get on a Medicaid waiver in Texas is not easy. We have a very long wait list. They say it's 12 to 18 years long. So I encourage every professional to get, when you're working with a family, I don't care how old or young the child is, I have told families of very newborn babies, let's call this number, we need to get you on this list. Because you don't want to wait till they're 12 or 18 years later to find out if they actually need this Medicaid waiver. This link on this slide is a link to a page in the Navigate Life Texas website where they explain Medicaid waivers in what I call parent-friendly language. Sometimes the information you get at the state level isn't always as parent-friendly as we'd like it to be. Next slide. And what you need to know about getting somebody on a Medicaid waiver list, the child does not have to qualify for services to get on the list. You don't have to qualify until your name comes off the list, and that could be 12 to 18 years down the road. All you have to do, and you also don't need to know what services the child is going to need or not need. That's not the point. All you have to do to get on this list is to give the child's name, date of birth, social security number, some demographic information, and you fill out a very brief 12 to 15 question healthcare questionnaire. You will then be assigned, or the family will be assigned, an ID number. Please help the family know that that number is critically important. It's how they keep up with where they are on that wait list. The state calls it an interest list. And once you have an ID number, you can go on the website yourtexasbenefits.com. It's a website managed by the Texas Health and Human Services System. And you can go on that website and find out where your number is on the list. But you can also, and this is critical, you also can keep your information, your contact information updated. Because if you move or your phone number changes and that child's name comes off the Medicaid waiver wait list, and all of a sudden they can't find you, you fall off the list. We don't want that. Next slide. And these are some phone numbers that you can use to get some information about the wait list. You can also call the local mental health authority in your area. We call them the LIDDA. If you just search Texas LIDDA, L-I-D-D-A, and your county, it'll pull up your particular LIDDA. It stands for Local Intellectual and Developmental Disability Authority. But just look up LIDDA and your county, and it'll give you your particular LIDDA's phone numbers. You'd rather go about it that way. And I always tell professionals, rather than give this information to a family that's just gotten a new, sometimes very scary diagnosis, make that phone call with them. Because too often, families go home with a load of paper and a load of information, and they're shell-shocked because they had a diagnosis they weren't expecting and maybe have just come out of an emergency situation. And the last thing they're going to think about is calling these numbers and getting their child's name on a Medicaid waiver list. It only takes 15 minutes. Do it with them. Next slide. And I will close with that. So we have about 7 minutes for questions. This is my contact information. If anybody had a question that I didn't address in my brief presentation today, And I thank Gladys for her help with this. And I'll turn it back over to you guys to see if there's any questions we need to answer. Thanks.
If you have any questions, feel free to throw them in the chat or the Q&A. I see someone has posted on there about Caitlin Hanley Act.
Where is that? Is that in the Q&A?
It's in the chat.
Oh, okay. I didn't see that. Yes, I'm glad you brought that up. Yes. The Caitlin Hanley Act is a very new piece of legislation, and it was passed, even helped pass by some friends of mine who went to the legislature and said, why are people not finding out about the Medicaid waiver interest list until they graduate high school and are in a crisis? And so the new law requires Texas schools to refer their students, any student receiving special ed, or if they're suspected of having any kind of intellectual or developmental disability, they are required to refer students to that local authority, the LIDA. And it can happen when the child starts school at the age of 3. It doesn't have to wait until the child's in transition age at age 14 and they start talking about transition age. I can't tell you how many times every spring I usually get at least one phone call from a parent who says, my son or my daughter's about to graduate and we don't know what to do next. And I'll say, so let me ask you first, is your child on the Texas Medicaid waiver interest list? And they'll say, what is that? So the Caitlin Hanley Act, named for and in honor of Caitlin Hanley, is entirely purposed to avoid that situation where parents and families aren't finding out and kids aren't finding out until the last darn minute. And then they're behind the 8 ball waiting for years for services that they really do need. And I see Robin. Hi, Robin. I know Robin. She says Lighthouse Learning Resources works on breaking the barriers you speak of, behavior guides, planning to support a child who cannot verbalize or who can, but can't clearly state their needs, just as most everyone. Thanks for sharing this very important information. Yeah, thanks, Robin. That's a great resource. Especially if a child's in crisis, they're probably not going to be in a great place to communicate that they're in crisis. Are there any questions? Any other comments?
Okay, well, I just want to thank everyone for coming. Lindsay, Laura, thank you so much for your presentations. We're hoping that people can walk away with information to be able to help families. And the recorded version of this video is not eligible for CEUs. If you have any questions, feel free to contact me, Gladys Pryor, at gladys.pryor@bcm.edu. Our next webinar is on April 15th at noon, and that is TAND in the first 3 years, early clues, practical management, and referral pathways. We will be sending out an email tomorrow with the CEU surveys, information on our next webinar, contact information for our presenters today, along with their presentations. And if you have any questions, feel free to reply to that email or reach out to us here at Baylor. So with that.
And anything, Gladys, this is Laura again. TAND stands for tuberous sclerosis associated neuropsychiatric disorders. And tuberous sclerosis complex is the rare disease that my son has. But they recently came out with a fairly new diagnosis that they call TAND, tuberous sclerosis associated neuropsychiatric disorders. And this doctor that's going to speak actually treats my son in Memphis, and she is amazing. It really helps people understand so much more than tuberous sclerosis is a rare disease, but there's a whole lot of other neuropsychiatric disorders that come under an umbrella of the name of tuberous sclerosis complex, and that's what she's going to talk about.
Thanks, Laura. So thank you again all for joining, and we'll see you next time.